We were talking the last couple of weeks about the basics of chiropractic and the basics of the #1 ailment in the United States, which is?
Back pain.
And more specifically, well, less specifically, chronic degenerative arthritis. Do you guys remember the picture I drew of arthritis?
Yeah.
How it dehydrates the joint? It's like taking the fluid out of the joint. Okay, so I talked to you last week about how Colleen and I started realizing the people we were treating in our practice back in Pennsylvania in the 1990s, we were doing 700 visits a week. Do you guys have a reality on that number? Yeah. Do you know how many? The average chiropractor, only 1 in 5 will ever see more than 200 in a week, even with associates.
Wow.
That's the stat. Most guys that, I don't know about CBA, but a lot of guys that come to us are doing between 100 and 200 visits a week. We're doing 700 visits a week. So we're seeing lots of bodies. That's what that means. I told you last week I gave the wrong number. I said 55,000 sets of x-rays. It was more like 55,000 x-rays. It was probably 15,000 sets of x-rays. But do you understand that? That's a lot. So I'm not good at x-ray because I was a really smart student. I'm good at x-ray because I did it so many damn times that I can remember what's on an x-ray. So we started seeing patterns is what I'm trying to get across to you. When you see a volume like that, you see patterns. When people come in, it was 9 out of 10 people were suffering with something today from something they did 10, 15, 20, 30 years before. Do you understand that?
Yeah.
And our goal was to figure out how could we better treat these patients. So we started looking and we came upon these doctors. And I mentioned them last week, but I'll mention them again. Dr. Rene Callier, did I talk to you about him? He's the one who talked about the head going forward. You remember the bowling ball analogy? And then Dr. Vladimir Yanda, he said when the head goes forward, just think about this. The muscles along your spine are small little muscles. That's what holds your head up. They have to behave differently than the muscle you're going to pull somebody up out of a ditch with. Do you understand that? This muscle, a phasic muscle, has to have explosive strength and can be trained to get stronger. But it doesn't have to do it very long. Do you understand that?
Boxing.
For boxing, I used to box, and the hardest thing in boxing is going round after round after round. That is the hardest thing to do, because you only get like a minute break and then you go back in.
Oh, yeah.
But yeah, endurance is what kills a boxer. So endurance is what we're talking about with these muscles. A phasic muscle, or a muscle of exercise, only has to have a short-term explosion, if you're talking about that contraction. Whereas a postural muscle, which are usually very small, and there's hundreds of them, there's so many, they name them in groups. They can hold a contraction for 36 hours at a time.
Wow.
I mean, we're all doing it right now. We're holding ourselves up, right? I mean, have you ever held, what's the longest you ever held your head up before you started doing this?
40 hours.
Yeah, there you go. She knew that real quick. But you see the difference. So the problem is this. When you start shifting your posture, you start using phasic muscles to hold yourself up. So if Chase and I are riding in the car, and we're sitting there and we're talking at the light, and bam, Roland comes up and hits us from behind. The car is going to move. We're going to fly. What's going to happen first is our head's going to hyperextend, straightening the curve out. So the seat rest, which should be here, but in most cars is here, now becomes a fulcrum and makes it worse. Our head goes back, and we go forward, and what stops us from going forward? Seatbelt. Well, you don't wear your seatbelt. Well, see, the thing is, the steering wheel, listen, the steering wheel is worse than the seatbelt because you could bust your nose, bust your sternum, bust your ribs. The seatbelt, you're just going to get whiplash, which can be bad enough, but you're going to get it. So when we get hit, we get out, we're all shook up, right? He has an adrenaline rush, I have an adrenaline rush, he has an adrenaline rush. Are you okay? Yeah, I'm okay. You okay? Yeah. I go home and I say, man, Roland, Chase and I were in an accident. What? How'd that happen? Are you okay? Yeah, I'm okay. So I go to bed and I wake up the next day. How do I feel? Sore. Was damage done?
Yes.
Yeah.
Even though I didn't go to the hospital.
Yeah.
When these doctors ask a patient, did you get hurt after the accident? They answer based on whether they went to the hospital or not. Oh no, I was fine. So I always started going, did you hurt the next day? Oh yeah. And as the day goes on, did you get better or worse? Worse. It goes on, you get worse and worse and worse. You have to leave work early. I was in a wreck yesterday, it's killing me, I gotta go home. So think about this. You got the little muscles that are weak and the big muscles that are strong. Which ones were hurt in the accident?
The little ones?
The weak ones, right. So which ones are producing the pain?
The little ones?
The big ones. Because now you're holding the bowling ball out here all day. Do you understand that?
Yeah.
That is a trigger point. If you do that for years, your body goes, I'm not going to use this muscle to hold this bowling ball out here all day. I'll just start knitting scar tissue in there so it holds it contracted all the time. If you do that, you lose range of motion.
Yeah.
If you do that, your postural muscles stop working, you lose posture. If you do that, you lose strength. So define an old person to me. Is this correct?
No.
Not normal, common.
Yeah.
Yes. Is this correct?
Yeah.
Stiff? Is this correct? Weak? That's what it comes from. Do you understand that? That's why somebody like Jack LaLanne or LD can be in as good a shape as they are and do whatever they want to do. How old was Jack LaLanne when he died? You guys know who he is?
Yeah.
97 years old. What did he do the day before he died? Worked out. Where did he go to school? Chiropractic school. Not many people know that. In the 1930s, he was in chiropractic school. So the point is this. We knew we were treating something that was decades old. And we wanted to incorporate postural change, so we thought, I figured, I'm married to a physical therapist. We'll put rehab in. That's perfect. We can do chiropractic and rehab together. Well, there's only a few states in the nation that do not allow a physical therapist to work off the referral of a chiropractor. And Pennsylvania is one of them. And that's where we were. So what we were told by the attorney was, Colleen, if you work with your husband and take referrals from him, kiss your license goodbye. So we're like, crap. That's an obstacle. So what do you do with an obstacle?
Go around it.
Find a way around it. When you're dealing with these clients, whether you're a coach or in Div 6 or whatever you're doing, they're going to run into obstacles. No matter what state they're in, they're going to run into obstacles. So what do you help them do?
Go around it.
Figure a way around it. That's right, a legal way. So our conception of integrating or bringing different licenses together was not based on making more money. It was based on a better outcome for the patient. And that's huge. And I'm going to write it up here because it's so huge. Better outcome. We were trying to find a better way to get our patients to a more complete fix. And what we figured out was, when I do chiropractic, you know, you tell somebody, how do you assess if somebody needs an adjustment? Well, you go up and you check their spine, you feel their vertebrae, and oh, that one right there is stuck. I'm going to adjust that one. So you adjust it, check it. Is he done? I guess. Turn your head. Oh, he can turn his head better. Yeah, he's done. When should he come back? I don't know. We were never taught this in chiropractic school. There's different theories. There's some chiropractors, hey Bob. Hey. There's some chiropractors that think this, well, come back when it hurts. Do you think you corrected that 30-year problem in one adjustment?
No.
Absolutely not. It's theoretically impossible, right? So then they go, come back 3 times a week. For how long? Until your insurance runs out. I mean, until your pain goes away. I mean, until you start complaining to me that you don't want to come in 3 times a week anymore. And this is what chiropractors do. In fact, they did it so often, they came up with a program called 3, 2, 1. Most chiropractors recommend 3 times a week initially, then twice a week, and then once a week, because they don't know what else to do. There has never been a study that says it is smart to reduce from 3 times a week to twice a week when you're getting them better. There has never been a study based on that. But it's taught in chiropractic schools to do that. It's ridiculous. So what I did was I said 3 times a week until I guess that you're better, and then it's once a week for the rest of the year. That was my care plan. So I would do like, I don't know, 4 weeks to 6 weeks to 8 weeks of 3 times a week, depending upon how bad they were, and then once a week for the rest of the year. Because I figured this, that would get that person somewhere between 70 and 100 visits of adjustments. And I realized that there's no other treatment they're ever going to get for the rest of their life that's going to improve their function more than what I did. That's how I justified it. But it wasn't scientific. I was guessing. Because remember the timeline? Remember the disease timeline? When do we say the symptom starts?
On the second half.
Down here,
Yeah.
right? So it's in reverse if we look at getting rid of the symptoms. When you start correction, the symptoms go away right here. Everything after here is a guess. I'm telling you one of the flaws with my profession, because we deal with people that are looking to change their program in their office. This is one of the reasons we did it. because this is a guess. So by doing this postural assessment, we can measure, is that length of that range of motion exactly accurate? And we do it with a computer. It's called a JTEC. Have you guys ever heard of that?
Yep.
Coaches, you have, because you're recommending your guys to get a JTEC. It's a computerized range of motion. We do it every 2 weeks. And we know what normal is, and you'd be surprised. Some of these people, when they come in, when they first get checked, they're like, instead of being 90 degrees in a certain range, they're at 20. We start working on them, and they get up to 40 and go, I feel great, I want to quit. We're like, you're only at 40 degrees. You got like another 50 to go. But I feel great. Well, then we show them the disease timeline. That's why I invented that. To show them, look, your symptoms being gone don't mean crap. You could have cancer and not feel it, right? So we tried to make it more scientific, and we did. You can grade a muscle in its strength on a grade from 1 to 5, or you can make it more simple and say, well, it's mildly weak, moderately weak, or severely weak. And we can measure it. And when we measure this, the insurance companies, the reason we win all of our audits is because they're used to chiropractors going, well, I told them to come in once a week because they didn't want to come in 3 times a week anymore. And we go, well, we told them to keep coming in 3 times a week because they were a grade 0 to start, and we only got them up to a grade 4, and 5 is normal. And we can prove it. We got a computer that measured it. We could do strength. Do you understand that?
Yeah.
So what we've done with AMI's system that we created is we actually made chiropractic scientific. Plus, we combined it up against other treatments. Like, for example, if you look at the joint, there's the bone, right? Here's tibia, and you got a capsule around there, right? And it's all deflated, and it's all dehydrated, and the cartilage is all messed up because it's not getting enough nutrients. When we stick that needle in there, and we put the fluid in, and it blows it up, so now you got a joint that's got more space because it inflated the bag. It's more lubricated. They can move better. They'll instantly feel better. You put stem cells in there, and the stem cells go to work repairing the cartilage. And now they're not like they're 20 years old anymore, but if it's a 55-year-old patient with bad knees, they could be actually functioning like they're 35. Do you understand that? That's what stem cells do. Stem cells, literally in your body, you have stem cells in your body. Everybody does. When you're born, 1 in every 10,000 cells is a stem cell. And the idea is it grows, it's called stem because things stem from it. It's like you put a seed in the ground and a shoot stems up and then branches stem out and then leaves stem out from there. Does that make sense?
Yeah.
Because stem cells grow into other tissue. They can grow into any tissue. In fact, every tissue in your body started off as a stem cell. Now as you get older, you get less. Somebody who's 80 has less than 1 in 2 million is a stem cell. So they don't heal as fast. Do you understand that? Stem cells reproduce. So when you get stem cells injected into a joint, they turn into new stem cells as well and keep working. Because they're live tissue, they're cryo-frozen. You know they can cryo-freeze tissue and keep it alive, right?
Yeah.
You know, like with impregnating women with frozen sperm, they've been doing that for 40 years. You know, if the sperm died, no baby would come out. But they've been doing it successfully for 40 years. So they do the same thing with the stem cells. When they thaw them out, they got 20 minutes, they got to get them into that joint, and then they go to work. Now, theoretically, we can't say this positively because the FDA says unless you got a little crew living in that joint saying, well, we watched them actually make the new cells, you can't claim it's growing new cells. But we take x-rays a year later, and a joint that looks like this now looks like this.
Wow.
And it might not be perfect, but it's definitely better than it was. And the patient's going, I can run up and down stairs for the last 9 months. So we found out that's a great service to add in because not only are we correcting the posture, we're getting rid of the subluxation, we're also getting rid of the arthritis to a degree. And we're actually reversing the timeline on this patient. Does that make sense?
Yep.
Yeah.
So somebody who goes through our program, and I can say this with 100% confidence, is going to do better than any other modality. I'll give you an example. If we didn't do stem cell injection to that knee, what could they do? Operation, right? Now what causes the degeneration? What type of tissue?
Scar tissue.
Scar tissue. Will surgery create more or less scar tissue?
More.
Way more. Do you understand that? Every time, and I've done this because when I first got into practice I didn't believe it, and I'd have patients bring in their paperwork. I'm supposed to get back surgery. Really? I'm scheduled next week. Can you bring in the paperwork so I can look at it? I was that weird. And I'd read it. And at the end I'd be like, there it is right there. This will accelerate your degeneration. This procedure we're going to do to you will accelerate your degeneration. And they have to sign to it. Now nobody reads all that, but it's in there. So they're saying, look, this is just a fix, a temporary fix. They're not trying to be mean. They're saying, look, we can get that knee to work for a little while, but it's going to get worse in the long run. Right? When they do a knee replacement, let's say they do that. Do you know they have to shave off this part of the bone?
Yeah.
And shave off this part of the bone? And they put a metal plate there. How long does it last? 10 to 15 years. 15 if you're lucky. So what do they do then?
One more time.
They shave off this part of the bone. And they shave off this part of the bone. And how long does that last?
Yeah, 15.
Yeah, and what do they do after that?
Nothing.
They shave off the bone from here down. They can only do it twice. There's not enough bone to keep shaving off to do a knee replacement. They can only do it twice.
So they just put a block of metal there?
No, they cut your leg off.
Oh, shit.
I'm not kidding you. To give you an idea, I've been in practice for 28 years. When I graduated school in 1991, if a medical doctor did knee replacement surgery on somebody under the age of 50 for chronic degenerative arthritis, it was grounds for malpractice. And now, we had over a dozen people come into our clinic in Chattanooga last year in their 30s who either had it or recommended it. So they just changed it in the last 28 years. If you go in and get that knee replacement surgery and the first one gets infected, when did they do the second one?
Right away.
A month later.
So then you're down to 10 to 15 years.
That's right. And if that one fails, how do I know that? I had a friend that was facing that. We did stem cell injections to him. It all healed up. Isn't that wild?
Yeah.
Yes, sir.
What if you have no cartilage whatsoever? It's bone on bone.
So it's a good point he makes.
That's me.
Bone on bone. Let me draw you a picture. Look at this, the end of this bone, right?
Medial. This is the inside.
Right? Looking this way, can you see space through it?
Yeah.
Looking this way, can you see space through it?
No.
So a lot of times the surgeon will give you a side view, which looks like this now. And they say, you're bone on bone.
When the x-ray shows just touching, it's just jammed up against that.
An x-ray is in two planes.
What's that?
An x-ray is in 2 dimensions,
Yeah.
not 3 dimensions. So even from this one, if they had the beam up too high and it was aimed down low, it would look like this.
Right.
So there are tricks that doctors can use to make it look bone on bone. Here's the test I use for bone on bone. Here's how the person comes into your office. Hold this for me. This is how somebody with bone on bone in their knee comes into your office. Because you can't
Move the leg.
put weight on it. It's too painful. And I very rarely have those people come in. So to give you an idea how horrific knee replacement surgeries are, sometimes they have to be done. Sometimes we send people off for it. But they happen so bad that the #1 form of patient that walks into our office, and we get 2 or 3 of these a week, just walking in and saying, I had this knee replaced, and I'll never go through that again, so what can you do for this one? It's over, I think, over 60% complication rate, which means they got an infection, it got stiff. My brother had his knee replaced, and he caught an infection. So they had to immobilize it and put a PICC line on him. You know what that is? That has this little pack taped to his arm that's got antibiotics in, and he's got to go in every other day and get it filled up with antibiotics, and it's constantly dosing antibiotics into his body. You know how bad that is for you? Where do you need bacteria to live?
In your gut?
Everywhere, but mostly in your gut, because you can't digest food without it. And if you don't have the right bacteria in your gut, you're going to become malnourished on top of everything else. What's the symptoms of that?
Everything?
Fibromyalgia, depression.
Death?
Yeah, I mean, just look at the sailors who were on ships when they had not enough nutrients. They would get depressed, their teeth would fall out, their joints would fail, they couldn't stand up, they'd bruise, their muscles would ache. So that's why they started putting limes on ships. Did you guys know that?
Yeah.
And what they called the sailors who ate them?
Limeys.
Limeys, exactly. Germans put sauerkraut on the ship because it was pickled cabbage, basically. Because they had to get vitamins in there somewhere, and if they put the cabbage in there, it would rot. So if they pickled it, it lasted longer. Do you understand that? No. So these are diseases that are just, they're giving them different names now. Fibromyalgia. I don't want to make, does anybody here have fibromyalgia? I don't want to make fun of it, because when you have it, it really sucks. But does anybody know anybody has fibromyalgia? Yeah. So what it is it's a breakdown in your Krebs cycle. Krebs cycle is how you process food into energy. And since it's not working, what happens is you end up with excess lactic acid, which is one step away from making energy. What does lactic acid do?
Makes your muscles sting really bad.
Makes your muscles sore after you work out. You work out too much, you break down your muscles, you get lactic acid, and you're real sore. Well, somebody with fibromyalgia has that happening to them constantly all day long in all 740 muscles in their body.
Oh, wow. Yep.
And because they're making lactic acid, they're never getting to the point of ATP, and ATP is your energy molecule, so they have no energy. So you have somebody with fibromyalgia, how do you feel? I'm really tired and I'm sore. That's why. It's a nutritional fix, not a drug fix. But that's why a medical doctor will never cure it. How much nutrition does a medical doctor have to get to graduate from school? That would be the big goose egg.
Really? Wow.
Yeah. How much does a chiropractor need?
A lot.
25 hours, which is pitiful.
Yeah.
So my first 5 years out of school, I got another 135 hours of nutrition. I could have got a minor in nutrition if I wanted to. I was working too much. But every time I went to continue ed, I went for nutrition. Does this make sense? Yep. So what we were looking to do was to put together a model that, one, didn't give up our purpose. See, our purpose was to bring something like chiropractic to the world. Chiropractic is a missing ingredient in major healthcare. Right? Everybody has spinal problems, and if you know now, if you have a spinal problem, you're less programming your brain. It's like taking the keys off your keyboard. Your computer's not going to work as good, no matter what. It could be cognitive, it could be the way your body repairs, it could be the way your body performs a Krebs cycle, it could be the way you think, anything. So we know if we restore that, that's going to improve. But that's not the be-all, end-all. We realized that had its limitations. There was no way to measure our improvement. Now with this model, we have a way to measure our improvement. When I used to discharge people, and you should understand this because you're going to be talking to chiropractors, and right now an average chiropractor goes, I see people 3 times a week until they bitch about it, and then I discharge them, and I keep them coming in. Or some guys go, I'm not going to stoop to that. I'm going to say once a week unless you hurt more. Or I'm not going to say anything. You just come back when you're hurting. I just got off the phone with one of our clients that's saying that. And I said, so how many of your patients a week are maintenance? Well, they're not really maintenance. Well, why not? Well, because they're coming in because if I don't adjust them, their sciatica flares up. So you never fixed them. No, if you fixed them, their sciatica would never return. In this model, patients who graduate, they're fixed. I don't think there's any other, and this gets broadcast, I'm going to deny this. So edit this part out. But it works so well that in my clinic in Chattanooga, when I say this to other chiropractors, like, you can see the sparks coming out of their ears, like, you can't do that. But they go, what do you do about your maintenance patients? We tell them, you can come in once a week, or once a month, on the 3rd Tuesday of the month, in the afternoon from 3 to 7, that little window, for free for the rest of your life. And they go, but I have like 9 million patients. That's because you never fixed them. See, what happens with us is a few of them come. All of them come the first week, but then the next month a few come, and then hardly any come. And you know when they show back up?
Never.
When they have a new injury.
Yeah.
Oh, wow.
A new injury, which is what the chiropractors are trying to do, stay connected to their patient base so they come back. The goal that I was trying to achieve, I had a clouded vision. I was thinking, I need to keep them coming and get adjustment. No, I need to get them to realize that that should be the first choice in healthcare. I get a problem with my body, I should go and check the spine first and then do the other stuff. So they come in, I got blah, blah, blah. This thing started my shoulder, this thing started my knee. I was shoveling snow, my back hurts. I was in a car wreck, my neck hurts. Thought I'd come here first, that's what we get. Do you understand that?
Yeah.
Does this all make sense?
Yeah.
So AMI's model is the only model in integration that actually does this. And we are the only integrated model. So do you guys know what the word integration means?
Put it together.
Yeah.
Yeah, see, multidiscipline is having a medical doctor, a nurse practitioner, a chiropractor, a rehab person in the same office. That's multidiscipline. Integrated means they're all working on the same patient at the same time. They have to coordinate their efforts, which is why we have what's called team meeting. You guys have heard of team meeting?
Yep. Yeah.
Yep.
I know you guys have. But have you heard of our team meeting? It's done before every shift where the medical staff and the chiropractic staff and the rehab staff sit down and they go over every new patient and every re-exam, which happens how often? Every 2 weeks. So we can keep measuring. So we definitely have a pulse on how they're doing, and we can change their care plan along the way. And our patients do get the best possible outcome. The most common thing we hear as a testimonial when patients leave is, I can't believe how good I feel. I can't believe I lost 20 pounds doing that rehab. Because it's the first time we're getting them to use their body, right? And they lose 15 to 20 pounds when they do the rehab program. Okay? Any questions?